show every year. This is Bill Tooley on the left. On the right is Bill Ballard, who's still a member of our faculty as research faculty. In the middle there is Sam Plunkett. This is obviously a number of years ago. Yes, it was now our chancellor. And when originally came here as a research fellow at CRI in the 70s, so he's been here for a number of decades. And so, once again, it's my pleasure now to introduce our Tooley professor for this year, Dr. Bryan Sexton. Dr. Sexton's the director of the Duke Center for the Advancement of Wellbeing Science. He obtained his PhD at UT Austin and was now a member of the Department of Psychiatry at Duke. He's a psychometrician that develops methods of assessing and improving safety culture, teamwork, leadership, and workforce well-being. So we're excited to hear him present today. So please welcome Dr. Bryan Sexton.
Thank you for having me. This is a fun lecture. If you haven't caught wind of the lectures earlier today, they're worth checking out for sure. I will say very briefly, I want to talk a little bit about what's happened in nationally in the well-being landscape in the past few years. Talk a little bit about the science, where it's going, and why there's a reason for hope when it comes to well-being in healthcare, and share some new data and lots of resources to share. But everything we're going to be talking about is about the quality of what we do. Like these anti-motivational posters like this one, quality, the race for quality has no finish line, so technically it's more like a death march. Thank you for meeting your targets this quarter. Now we're going to move you into a new building, go live with some new technology, turn over your leadership team twice in 6 months, and good luck meeting your targets next quarter. Rinse, wash, and repeat. No wonder stress is high. But stress isn't just high in our work settings, it's also high at the societal level. And I want to acknowledge that 2025 was a dumpster fire year for academic medicine. It just was. And when you no longer feel certain about where stress is coming from, you have to scan the environment for all possible incoming sources of stress. And that is exhausting. The good news is we have ways of measuring that and understanding that and counteracting. I'll talk a little bit about that. I want to draw some attention early on to some work by Jim White, a colleague of mine at Duke. He's done this with colleagues at UCLA and UCSD, Brigham, and other colleagues at Duke, where they look at biological age. I just want to say this very briefly. If you look at mammals, mice, dogs, humans, and you stress them out, if you look at, I'm a 52-year-old man, if I'm undergoing trauma surgery, or you have someone who's pregnant, or you have someone who's got a severe case of COVID. Those are examples of severe stressors. And what they do is they, using a whole lot of different ways of measuring biological age, they all are converging into the same numbers. It's interesting. But your biological age increases when you're under stress, and it only goes back down to meet your chronological age when you have a period of recovery after that stressful encounter. The problem that we have in healthcare, especially now, is that we blow right past that time where we should pause and take a break. We wait till we're hanging off the edge of the cliff with our fingertips, and we say, I should probably take a break pretty soon, and then we still don't. And that's kind of the norm that we've adopted in healthcare about the need for recovery. So as we talk about well-being during this lecture, I just want to give you a slightly different take on it, if I can, just for the next 30 minutes. Please don't think of well-being as how happy you are. Please think of it as the ability to do stuff. So if your well-being is compromised, your ability to do stuff is also compromised. What we now know, psychometrically speaking, the best measures of well-being are measures that have a component of your ability to do stuff. So what if I were to tell you there was one metric, one variable that was so powerful, it can predict things like, if I answer your quality improvement readiness, or what do I think of my medical director or my nurse manager, or what do I think of my teamwork, or I'm going to speak up and resolve conflicts, or to go to patient safety norms, that I feel safe being treated here as a patient. What about my work-life balance? Do I work in a place where people pee at work, or do I work in a place where nobody pees at work? And that kind of depends on where you work. Psychological safety, do I have a voice? That's a big one. Emotional thriving, this is what a lot of us call professional fulfillment and emotional recovery. Do I bounce back after people? What if there was one variable that did a pretty good job of predicting all of that? What if I told you that variable is called emotional exhaustion? So Yoga Prophet, who's here in the front row, and I published an editorial last year explaining workforce well-being in healthcare is workforce readiness. It just is. It's a fantastic predictor of what's to come. And if I were to break down the two most important components, we've got huge data sets that are international now. The most important cultural components in healthcare right now in any work setting is psychological safety. Can you open your mouth when you're concerned, uncomfortable, scared, or if it's kind of like new? And well-being, which is best measured by emotional exhaustion, which we're going to come back to. And I want to make sure that you all have an opportunity, not just to see the data and judge for yourselves what I'm saying, but I want you to, at one point, take out your phone, and I'm going to give you the 5-item emotional exhaustion scale, and you'll get to step on the scale and look at your own emotional exhaustion, where your well-being fits into all the stuff that we're talking about. But these two domains are really psych safety, which is culture, the way we do things around here. Can I open my mouth when I'm scared? And then well-being, the ability to do stuff. For whatever reason, in the past few years, it's become more difficult, not less difficult, to find your voice. We were getting better at it for a little while, like the teamwork forum for improving in healthcare, and then they kind of fell off the cliff. Now, here's one more anti-motivational poster for you. Survival: when you're in deep trouble, say nothing and try to look like you know what you're doing. Just so you know, when it comes to, if you've ever heard the saying, when it's better to be thoughtful and say nothing than to open your mouth and remove all doubt. There are a lot of disincentives to voice in healthcare, but we're talking about psychological safety. This is Amy Edmonds' research at Harvard. It's the belief that you're not going to be punished or humiliated for speaking up with ideas, questions, concerns, or mistakes. Why don't we speak up? There's two primary drivers of that. And both of them can be addressed with some of the interventions that we'll be talking about today. But one of them is, I don't want to speak up because I'm afraid. And the other is, what difference will it possibly make if I open my mouth? Those are the two big drivers for it. But there is a way to improve both of these. And this goes back to a lot of research that Jochen Prophet and I have been publishing over the years together. One of them looks at rounding. Now, there's lots of different rounding formats. I want to talk about different rounding formats today, but a traditional, like 1999 patient safety, like really before patient safety was a thing, rounding format was you kind of walk into a clinic or clinical area, you say, so how are we going to harm the next patient around here? And what can we do to prevent that? And in 1999, that was a fantastic way to surface quality and safety related issues. In 2026, that's a really good way to get something heavy thrown at your head. Instead, I suggest you look at the positive rounding frame, which is really good for psychological safety and for the well-being of the healthcare workforce. And that is, what are 3 things that are going well around here? One thing that could be better. That slight difference, that subtle shift in the way you ask that question, gets people to talk about what they're looking forward to, who they want to give a shout out to, what gives them meaning at work. Oh, and by the way, if we could just get an IV pole with some wheels on it, we could ambulate our patients more quickly, get our length of stay down, and boy, that would mean a lot to us. So I feel more comfortable talking about the stuff that's broken if you let me talk about the stuff that's not broken first. That's about psychological safety. Now we published this, and the Joint Commission, we did a press release, and there's no way of doing rounding. And if we line up 400 work studies where we did this year, the red quartile, the fourth quartile, where we don't do a very good job. This is the percent of people in each work study who said, yes, I'm asked about what's going well. And compare that, the green in the first quartile here, 100 work settings versus 100 work settings. In every single cultural domain that we measure, quality improvement, readiness, local leadership, teamwork norms, patient safety norms, it's always better when being asked about what's going well. Look at emotional exhaustion, it's the reverse pattern. When you ask me about what's going well, I feel less emotional exhaustion. Burnout climate is, how crispy are my colleagues? Well, they're less crispy when I'm being asked about what's going well, and even work-life balance is better. But wait, there's more. We decided a few years ago to actually develop a scale, and I want to give full props to Amy Edmonds, who put the concept of psychological safety on the map. She's written a wonderful book on it. I highly recommend the book. And I'm a psychometrician, so we develop measures and then validate to show that they measure what you think they're measuring. I have to say, her scale is kind of just barely okay. Like on the grand scheme of things, it's okay. Like you can use it for research, but it just barely meets the the kind of the cutoff for something you can use to, in research studies. So we created a scale that would do something similar, but it would have better psychometrics. That we call it the psychological safety scale. And part of the validation of the scale, we wanted to look at what is the impact of traditional safety rounding relative to this psychologically safe rounding or this positive, rounding format. So on two panels here on the left, panel A, that's traditional safety rounding. On the panel B on the right, that's positive rounding or psychologically safe rounding. What's kind of interesting here is we actually assumed in the research that safety rounding would be better for safety culture, for safety climate. It wasn't actually. It did work for safety climate. Those are the t-test. There's a 3.5 is statistically significant, but it's twice the effect size in positive rounding. Not only was it better for positive rounding than safety, but emotional exhaustion and psychological safety, these two domains, which I cannot emphasize enough, that that's, if you get that right, everything else falls into place in your clinic and in your work setting. So we also have an item. This is a fun item. That we asked across the state of Michigan through the Michigan Hospital Association. Those were our colleagues in the Michigan Hospital Association. This is, we also learned a lot in this study, including the item, my medical director, my nurse manager, regularly makes time to provide positive feedback to me about how I'm doing. That item about leadership. For every 10-point increase in that item, you see a 3-fold reduction in your odds of getting reporting burnout. Let me just say that another way. The way I view my leader and the way I view my well-being are tightly woven and tightly connected. It's very, it's a Gordian knot that's difficult to untie. But don't take my word for it. Colin West and Lottie Derby have shown the same thing at the University of Colorado at Mayo Clinic. Totally separate sample, totally separate scale, same basic finding. My immediate supervisor encourages me to develop my talents and skills. #1 predictor of burnout in their study as well. So I'll go one further and say that David Hurtado at the Work in the Sciences Center and his colleague Abigail Lenhart have done some really interesting work with what are called well-being check-ins or work-life check-ins. Now, this started in primary care clinics where they noticed during the pandemic, they were surveying something like 30 clinics, and 2 of the clinics had burnout levels go down during the pandemic. The other 28 clinics had burnout levels go up. So they went to go look, what were these 2 clinics doing? And they found that the managers in these clinics were doing once a quarter, 10-minute check-ins with each of the staff that worked there, just to ask about how they're doing. Now, that doesn't mean that the manager was fixing all the problems that were surfaced. It was just that they were carrying that knowledge with them as they went forward. Those 10-minute, once a quarter work-life check-ins were remarkably powerful in reducing burnout, in particular emotional exhaustion, but also elevating what's called organizational values alignment and senior leader values alignment. People felt like their mothership had the same values that they did when their work-life experience was kind of pulled out and made part of their day-to-day interactions with their leaders. So there's a number of different formats. There's emotional support rounds, which we did during the pandemic. These are crisis rounds, like during Delta and Omicron. We weren't going to say, what are 3 things that are going well around here? We didn't say that during Omicron, right? But what we did say is, can I get you something to eat? Can I get you something to drink? You need to talk to somebody right now. Those were crisis support rounds. Then we have patient safety focused round where we're just asking about what's wrong in our work setting. And then positive rounds where we ask about what's going well and what could be better. And then these leader check-ins. Now, as we look at all of this, the emotional exhaustion domain, which is all the stuff that we look at in healthcare worker well-being, it's really, really powerful. I want to say not only does it predict culture, it also predicts patient engagement and infection rates and medication error rates and standardized mortality rates. And I just want to pause here and say this is not new. This slide is actually over 10 years old. So we've known this for a while. It's a pretty robust indicator of how things are going. Not only that, for every 1 point increase in emotional exhaustion, you're 20% more likely to step away from the bedside. So let me show you what we now know nationally This is work that Profit and our colleagues did together. We tracked 30,000 healthcare workers since before the pandemic, September 2019, since before COVID, same 30,000 people in September 2020. So that's after the pandemic started, but before vaccines. That was a hot minute, remember that? And then the same 30,000 people again, September 21. So that's after Delta, that's after vaccine mandates, and it's in the middle of Omicron. So same 30,000 people, but three very different times. And what we found was interesting. I won't bore you with all the details, but basically there was an 8.6 point increase in emotional exhaustion. That was a 27% increase. That's an almost 9-point increase. Now, what I just told you was that other researchers have already shown that for every 1-point increase, you're 20% more likely to step away from the bedside. So no wonder it's so difficult to keep our units staffed and to keep leaders in their roles right now. We have these drivers kind of pushing them in a different direction. Just to give you, put this into perspective, that 9-point increase, by the way, it wasn't just emotional exhaustion. We saw the same 27% increase in anxiety, 27% increase in depression, and 27% increase in emotional exhaustion. So it's not like it's surprising, it's just that we measured that, and what I can say, relatively speaking, that's like going live with 2.5 to 3 different EMRs back to back with no break in between in the same year. We've never seen anything like that. Nobody's ever done that before. That's why the whole thing felt so different. So let's say a little bit about emotional exhaustion, and I want to pull this back to the drivers of what makes it so hard to kind of feel good about what you're doing at work. One of them is well-being is the ability to do stuff. And emotional exhaustion is the best way of looking at that. I think it's powerful to point out that physician intentions to leave are highly predicted by your emotional exhaustion. So this is physician intentions to leave, APP intentions to leave, nurse intentions. Those are pretty high correlations there. So the more exhausted I am, the more likely I want to talk with my feet and leave. But also then here's this leadership link again. The more exhausted I am, the less positively I think of my leader. So that leadership well-being connection is very consistent. I'll just say this very briefly. It's really hard to find someone who's perfectly happy and content and they have a shitty boss. We just can't find that. Everywhere we look, we just can't find that. So I'll say something really briefly about what we found in our own dirty laundry at Duke, and that is we've measured emotional exhaustion and linked it back to not intentions to leave, but actual turnover rates and actual patient harm. So this is, we use RL Solutions as our incident reporting system, and this is a preventable medication-related patient harm was predicted by emotional exhaustion. What's interesting here too, I don't know who y'all use at CSF, but at the time we were using Press-Ganey for our employee engagement survey, and I'll just kind of, no disrespect, but maybe a little disrespect, but Press-Ganey, which you see here, the NS there stands for not statistically significant. Nothing on the Press-Ganey employee engagement survey predicted anything, any of our clinical or operational outcomes, but well-being did. So our well-being predicted both clinical and operational outcomes. Let me go one further. And this is in Kyle Rader, he's a pediatric intensivist at Duke, a friend and a colleague of mine. He's actually shown that if we take 319 work settings and we kind of rank them, least to greatest in terms of who's the most burned out. This time, the first quartile is on the left side because you want emotional exhaustion to be low. Let's compare low burnout units to high burnout units, the red there. What do you think the link is when it comes to working in a unit full of people who are emotionally exhausted versus full of people who are not emotionally exhausted, when it comes to things like communication breakdowns and whether or not somebody's going to act impolite or maybe out of character? What's the likelihood of disruptive behavior events in the left-hand side versus the right-hand side? And what I can tell you is that in every single disruptive behavior that we looked at, it was a dose response. The more emotional exhaustion you have in your work setting, the more bullying you have, more publicly humiliating others, turning your back before conversation is over, hanging up the phone before conversation is over, making comments with sexual, racist, or ethnic slurs, and even physical aggression. So those disruptive behaviors go up as emotional exhaustion goes up. That's 1. 2. The more emotional exhaustion you have, the more your intentions to leave go up very directly, very linearly. Now, all of these data, emotional exhaustion and intentions to leave and disruptive behaviors, this is pre-pandemic. So the rates of intentions to leave, exhaustion, and disruptive behaviors have all gone up dramatically since the pandemic started. But we already had that link before the pandemic. I want to draw some attention to some work that starts to unpack this in a way that I think is kind of compelling. This is data from Tim Huseth and Andrew Smith, and they've actually looked at moral injury, and they have this acronym called potentially morally injurious events, or PMIEs. And they tracked like 500 physicians over a number of years and looked at the physicians who were exposed to potentially morally injurious events, who stayed and who left, and who reduced their effort. What happened to their well-being? What happened to their burnout? And something really interesting came out of this data, and it's probably the only data set that I'm aware of right now that can look at this. Let me just make this clear. Something really horrible happens on a Wednesday at work. Were you directly involved, or did you witness it? Because whether or not you were directly involved or you witnessed it matters a lot as to how this impacts your well-being. If you see something horrible happen to others, you're like, forget this, I'm out of here. Your turnover intentions go through the roof. But if you participate in it, if you're involved in it, if it involves yourself or a sense of significant betrayal, if you feel betrayed by the mothership, what happens then is you don't leave, your intentions to leave do not increase, but your burnout skyrockets. So you stay. So if you see it, you leave. If you do it, suffer while you stay. So it makes a really big difference as to your proximity to that horrible thing that happens, as to how we interpret it. Now, this is something that I pulled together. We didn't know what was going to happen in time for this lecture, but we got these data 2 weeks ago, and this is we collected the data across 4 hospitals on challenging events from the past year. This is 2 weeks old. This is not, we're not even in manuscript drafting mode yet, but we put these slides together just so you all can see this. What are challenging events? They're going to be things like challenging patient-family interaction, coworker death of serious illness, workplace violence, bullying, and then emotionally stressful adverse patient outcomes related to care or unrelated to care. Those were the categories we looked at. This was across 178 work settings, about 4,000 people. What I can tell you right now is that the 2 that really pop are workplace violence and bullying. Those are the ones that if that happens, your culture tanks big time, your well-being tanks big time. So I figured I'd share this with you. This is the first time I've ever shown these slides. Across 178 work settings, these are the rates of people who said yes. This is the percent of respondents who reported yes in the past year they've encountered a challenging patient or family interaction. Okay, so that's probably to be expected. Here's what it looks like for workplace violence, and I want to point out, challenging patient family interactions are pretty common. Workplace violence, when it happens, it doesn't happen to the whole unit specifically. It usually happens to a small number of people on the unit. It reverberates and it affects the rest of the unit, but the people who witness it directly is pretty small. Here's workplace violence prevalence, the same 78 units. But here's what happens if you just look at bullying, emotional abuse, and discrimination exposure in those work settings. This is in the past year. This isn't ever. This is just in the past year. Now, if I go back and we look at workplace violence, what I can tell you is that those individuals who are exposed to workplace violence versus not exposed made a big difference in their emotional exhaustion and their intentions to leave. There was a really big difference in those 2 areas. But when we look at the bullying data, if you're exposed to workplace bullying, emotional abuse, or discrimination, it doubles your intentions to leave. It doubles your burnout. And that's interesting because I could never say this. Well, these data changed what I've been saying for the past kind of 10 years. So let me share, I want to share with you what I've been talking about for 10 years and then how these data kind of turn that on its head. So in 2017, you were asked by patient safety folks, risk managers, folks at Duke, because we wanted to open a peer support program at Duke. And we were, I don't know if we really need this peer support stuff. Well, let's see. So we We put a question on our annual survey that everybody got, 400 work settings, 80% response rate, over 10,000 respondents. We published this data, you open and I published this data together. I want to read you the question. Now you're familiar with the concepts of second victim, first victim of harm, the healthcare workers involved, second victim. We couldn't use the term second victim because it's controversial, because family members then say, well, my family member who died is the first victim, and I'm the second victim. You're not the second victim, so that became a controversial term. Now you still Google second victim if you're searching this literature, but basically we couldn't use that term. So here's the language that we used. Forgive me for its complexity. Individuals emotionally traumatized by an unanticipated clinical event within my work setting receive appropriate support in this health system. So what we're looking at is the percent who either agreed slightly or agreed strongly with that item. Again, we put them into these quartiles. And we do this quartile work like this because it's very difficult to separate an individual's experience from the experience of that work setting. So when you just look at the entire work setting together, it makes it methodologically, it's just a lot crisper, cleaner. Well, the same thing, what I've always said is look at the differences by these quartiles. Quality improvement readiness, where I think of my leader, my teamwork, my patient safety, look at my burnouts lower, if I feel supported, how crispy my colleagues are less crispy, and across all of these variables except for work-life balance, you're better off if you feel supported by your mothership on your worst day at work ever. If you feel like your mothership has your back on your worst day ever, you're in it. You're bringing your A game every day. Now, if you ignore work setting and you just look at all of Duke, and you just group them all together, this is where it gets interesting. So this is 2,000 people who said, yes, I feel supported. That's the green. The red is 1,500 people who said, no, I don't feel supported. Look at the differences by improvement readiness. What do I think of my leader, and my team, and my safety, and am I burned out and less burned out? Am my colleague burned out? They're less burned out. Even work-life balance work in this one. What I've been saying for 10 years is that if I feel like my mothership has my back, that's the biggest differentiator between a good culture and a bad culture, a good well-being and bad well-being that we have ever seen anywhere in the peer-reviewed literature. Does my mothership have my back? I can't say that anymore because workplace bullying beats that. Workplace bullying now is more important than whoever feels supported by my mothership because it's a bigger differentiator. So that was my lesson learned. So that's all doom and gloom. I know it's terrible to talk to grand rounds about like, oh, no, there's more reasons to feel horrible about everything in the universe. Let me just kind of change that for a second and say there's a reason for hope. And I know that there's great data behind meditation, exercise, diet, and yoga. There's great data, yes. But when you're exhausted and somebody tells you to kind of put your ankle behind the back of your head, that's just like, it feels like well-being malpractice. Nothing against yoga, just like that's really your first stop when you're trying to feel better. So we created a number of bite-sized interventions, starting in the NICU. The NICU really showed us so much about how to do this right. We reviewed over 200 different interventions for bite-sized strategies that healthcare workers could use to put some gas back in their tank. And out of these 200 interventions, we applied these criteria. Whatever this intervention is for busy, tired, cranky, distracted, overwhelmed healthcare workers, it better be easy to do. It can't take very long. I want to feel better right away, and I want to feel better for a long. I don't want to feel better for an afternoon. I want to feel better for months. And so, using that criteria, 219 interventions, 5, maybe 6 if you're generous, but 5 met the criteria. We put them into our NIH-funded research. We created an intervention called WISER. We published it in J. Perry. We actually showed that we can pause emotional exhaustion, go down, stay down for 6 months. We can pause problematic work-life integration, go down and stay down for 6 months. This is exciting. Fun fact, we actually showed at the 1-year follow-up that between the 6-month and the 12-month follow-up, emotional exhaustion continued to go down. So now, usually, when it comes to medications like SSRIs, if you go off of your antidepressants, in a couple of weeks, it goes out of your system and the effect melts. But here, this was a 28-day intervention, after which there was no, continued, we didn't continue to give them the intervention, but they continued to get better between 6 and 12 months. So this is called skills, not pills. It's a little different. We then took it out of the NICU and expanded. Now in the second study, second randomized control trial, we did it And then we actually showed that it works outside the NICU as well. This had NICU people in it, but here we reduced the length of the intervention from 28 days down to 10 days. And so we showed that we can cause emotional exhaustion to go down, stay down for a year. We cause depressive symptoms to go down, stay down for a year. We cause, problematic work-life balance to go down, stay down for a year. Fast forward, and we're doing a podcast with the editors at JAMA, and they kind of made fun of us and said, so this is 1 to 2 minutes a day for 10 days. Okay, do the math, that's 20 minutes. Why don't you just put this into some CMEs? Why don't you just make this like a CME specific intervention? So we did, and we ran as a control trial too. We showed the same results. Here we have it. We actually reduced it here down to 8 days. But what I showed you before was that the pandemic for 3 years was responsible or associated with a 9-point increase in our exhaustion. And now using a continuing education intervention, we can cause emotional exhaustion to go down that same amount in 8 days. Like that gives me hope, right? Like it looks like we're headed in the right direction for bite-sizing this stuff and making it accessible, these micro interventions. So here's what I'd like to do. Y'all are game. Is I want to show you how we went about making this even more interesting and accessible for busy, tired, cranky health workers. We did it by, I guess I have to start by saying, in most well-being kind of psychoeducational behavioral interventions like smoking cessation and weight loss, they have pretty bad retention. They average about 25% of people that you enroll in your study actually finish your study. We were in our work together, Jochen and I, we were getting about a 50%, 54% retention rate in our second randomized control trial, but that wasn't enough. And so we found if you instead give people feedback about how they're doing, so you don't just collect the data from them, you also say, here's what you just said. You just step on the scale and here's your numbers. And here's your numbers relative to other people in your profession. That feedback and interpretation it created a moment of what we call in the psychology world behavioral activation, like, oh, snap, I need to do something about that. And in that moment, if you can give them a micro intervention to complete, the compliance is really high. So here's how we did that. We would do an assessment, we give them some feedback about that assessment, and then we give them an opportunity to improve that number that they just got. I'd love to show you how to do this, and what it requires is that you put your phone into camera mode. Does anybody have a mobile phone? Does anybody, might have with you? I'll put a QR code up on the screen. It'll ask you 5 questions. This is not a research study, so we're not asking you to enroll in anything. We're just going to ask you 5 questions and then show you your score and how that relates to your kind of well-being program. So here is the QR code. You should see something like that pop up on your screen. I put up a 2-minute timer. It will not take you 2 minutes to do this, but at least you'll get a chance to see what it is. I'll stop talking, give you a chance to step on the scale, look at your numbers, and look at your feedback. And in the end, we'll give you some tailored, bite-sized suggestions. give everyone a chance to answer those questions and get your feedback. All right, so for what it's worth, there are two very common reactions to whatever you just did. One of them is, yep, that's about right. And the other is, oh my God, oh my God. And both of those reactions are perfectly valid. I want you to know that for what it's worth. You should have seen something like this, where it gave you a blue score. That was your score. And then you can interpret it based on these numbers. This is the cutoff for severe exhaustion, moderate emotional exhaustion, mild, or not exhausted. For different profiles, for these different numbers, you have different interventions. And I just want to say, if you're a 1, which means you've got high emotional exhaustion, you're in good company. 55% of us have a 1. That means whatever we do for you, it better be the lowest possible threshold or barrier to entry. It needs to be really, really straightforward, easy. We've got to give you the simple stuff. And if we do that, we can then give you more complicated well-being interventions later on. But that was an important lesson for us. If you're a 3, which means you have very low emotional exhaustion, it's about a quarter of us. First of all, keep it to yourselves. We don't want to hear about how you're doing right now. Good for you. Good for you. We resent you. But each of these interventions have, each of these profiles of well-being have different interventions that match to them most effectively. And we know this because we put the emotional exhaustion scale at the front end of all the other interventions. So we can go back and look at tens of thousands of respondents and see the ones who started with this level get the most benefit. So we can actually recommend those interventions to you at the outset. Now, I'm not sure if this is set up to work, but I figured I'd show you a couple of what these interventions look like. We have created at Duke, this is, not everything is really popular right now, but this is one of the things that we're doing is really popular right now. We have what are called well-being 1-minute wonders. So we kind of distill a well-being concept and tool into a 59-second video so that people can see, is this something that I'm interested in doing? We try to kind of bite-size the kind of presentation of the tool itself. So let me see if this will work. Y'all can hear this. This is the well-being 1-minute wonder on 3 good things.
Today's topic is the science of 3 good things. We notice, remember, and react more strongly to the negative. It's why social media prioritizes doom scrolling for engagement. This negativity bias makes us vulnerable to getting lost in the negative, but we can train our brains to re-see the positive stuff we've been ignoring. This randomized controlled trial of recalling 3 good things caused depressive symptoms to decrease. Encouraged by this, we asked healthcare workers to reflect on 3 things that went well daily for 2 weeks. We found that emotional exhaustion, depressive symptoms, and problematic work-life balance were all decreased by day 15 and stayed decreased for 12 months. Even during challenges and uncertainty, taking the time to search for the good things that are there improves well-being. So try the tool and check out the monthly well-being session on the science of the things. The negative screams at you, but the positive only whispers. Let's make it a little louder. And that was your well-being 1-minute wonder.
So you see how that in a minute we can show you the concept. The QR code's there the whole time that you can click on it and see if that's a tool you want to use. That was one of the tools that is suggested for someone with a profile of 1. So for the highly burned out people, that's a very popular tool. I can show you another. You want one more before we go? Show you one more. This is the one for cultivating on wonder. That's one of our favorites, actually. That's always a really fun. So on wonder. Here we go.
Today's topic is the science of awe and wonder. We feel awe in the presence of something vast, mysterious, beautiful, and moral courage, collective movement, music, art, and spiritual contemplation. Feeling awe reliably boosts our well-being. When researchers ask participants to search for awe, they have more life satisfaction, patience, they volunteer more. Get this, they have an increased sense of time available. Who could use that? Awe increases your immune system function with lower levels of pro-inflammatory cytokines. Dose response effect, where experience more awe, report less daily stress, and being less bothered by daily hassles. So try the awe tool and check out the monthly well-being session on the science of wonder. Well-being, patience, life satisfaction, immune system function, all from noticing things that are amazing. It's pretty cool. Now, well-being 1 minute.
we're trying to bite-size this stuff and make it simple to present it, to talk about, to share it at a huddle, to share it at a staff meeting, to share it like during grand round. So like that was the whole idea behind these tools. Now, we recently just conducted a well-being pulse across all of our clinics. There are about 300 clinics at Duke Health. And our burnout level, even though it's gone down since the last time we pulsed, it's still way too high. So we're working on that. What we were able to do is to go to every single clinic and say, if your burnout rate is, 40% reporting burnout or more, then we want you to do those profile one tools, the simplest possible tool. That's going to be working on sleep or gratitude or pretty good things. But if you've got fewer than 40% reporting burnout, you've got a little bit more gas in you can do more complicated things in your work. So you can promote different tools, like the work with integration tool we have on Hope, or we have on Humor called Three Funny Things. Or you can choose your own strategy, but make sure that what you're doing is evidence-based. Every month at Duke, we have a different topic where we cover things like the neuroscience of hope. We have one on sleep. We have one on good things, on wonder, gratitude. We have one on how to work with a jerk, which is particularly popular position. We have one on processing grief, and we're on using humor as a well-being strategy. We have one on a random acts of kindness. You can see the topics are pretty diverse. So every month you can choose to go to a different topic. The idea is that if you're going to need to kind of cultivate a number of CMEs anyway, why not do it on well-being? And while doing it, have access to a tool that you can use. When we put together the 5-hour continuing education RCT that we talked about, and the 12 hours of the month, that's how we train our well-being ambassadors. We used HRSA funding to actually train 17,000 people nationally to be well-being ambassadors. 800 of them are at Duke. I'll be honest with you, almost 300 of them have already left Duke. So we're constantly having to replenish the ambassadors that we train because there's a lot of churn right now. But I hope that what you've seen is whether we're talking about peer support or positive rounding or these interventions, they give you a chance to pause and reflect on things that don't suck. And that's useful because we don't typically take the time to do that. So we can retrain our brains to notice the good stuff that's right next to the bad stuff. Randomized control trials show that it works, and this is an exciting time for this well-being science. The science is finally catching up to the needs of the moment, and it's getting easier to help healthcare workers to do the right thing for their well-being in an evidence-based way. All this is available on our website for free. Cause.dukehealth.org. Cause stands for the Center for the Advancement of Well-being Science. Dukehealth.org. We have institutional resources on the left. On the right, we have a lot of individual resources. Also, if you're on social media, you probably shouldn't be on social media, but there is one platform that we're still on, and that's LinkedIn, because of all the platforms, the fewest people actually death scroll on LinkedIn. There's just so much LinkedIn you can take. They're like, ugh, I gotta go to something else. So we still release interventions and studies and videos and things on LinkedIn if you want to get access to it that way. But with that, I'd love to open it up for some conversations. Feel free to push back on anything that you've heard. Feel free to ask me to clarify something better if I can. I'd love to hear your thoughts or reflections. Yes. What is the specific definition of workplace violence? Yeah. So it came at the back end. It's basically the end of a survey on culture and well-being that we gave to all like 4,000 of these people. And it was, in the past year, I have experienced the following. And it said, workplace violence. Yes, no, not sure. Those were your options. And so it's left to you to interpret that. And when we're comparing it, we're only comparing the people who said, yes, I have, to those who said, no, I have not. So that's where we're leaving out the not sures. Actually, no, there's a much larger number of not sures when it comes to like, are people doing leader walk rounds in my unit? There's that numbers. I don't know if they're doing walk rounds. They're never there when I'm there. Versus workplace violence, that's a much narrower band, if that helps. Can we use that same exposure variable? Yes, no, not sure, for all kinds of like exposure events. Yes.
So I asked the second, days, and then we saw the movements of the drop from 6 months to 12 months, further decreased. How does it explain that? Do you think that people adapted the
I love this question. So the question is, what is happening between 6 months and 12 months that we see emotional exhaustion continue to decline? So it's an exciting finding. I admit we were super jazzed. Number one, we're like, ooh, another publication. So we're like excited. But number two, I think what's special about it is that when we look at open-ended comment participants, they'll tell us a year later, I still do 3 good things with my family at the dinner table. I say, here's what I'm still doing. And they have their favorites because we had 5 interventions that we were testing in that study. And the 2 that were like really, really popular were the gratitude intervention and the 3 good things intervention. In the second randomized control trial that we did together, we actually showed that if you give people a choice, they'll choose those interventions over other interventions. So the first intervention, we just gave all the interventions to everyone, all the different well-being activities. We give all of them to everyone. The second one, where people kind of choose. And so that taught us a lot about where's the stickiness of this. And so I think the stickiness of some of those interventions, it's easy. So at dinner with your family, you just say, hey guys, what are 3 things that went well today? And then you go around the table, or you can do it at a huddle, or you can do it, at a staff meeting. It's a tactic that's kind of agnostic to application. We've seen people do 3 good things with group texts. We've seen them do 3 good things by putting up a whiteboard outside their office door where you can put some butcher paper in the break room without some Sharpies. Write down the good things. So it's pretty agnostic to application. It's the simplicity of it. But I will tell you this, it only works. You only get these lasting effects when people are doing it at the beginning every day for 10 days. If you only do it 3 of the 10 days, we don't see that effect at 6 and 12 month follow-ups. There's a dose. That minimally effective dose is that you have to develop the habit of doing it. It's a great question. Thank you. Yes.
sharing grouping multi career to be getting me that in conferences with the next brand to show our groups or identity or
Yes. Yes, it's a numbers game. A lot of that, so to make sure you have a big enough pie to kind of cut it into different pieces of it. We've done work with Daniel Topic and Tate Shanafeld at Stanford, looking at some of this. What I can tell you is the differences between races and ethnicities is not. It's statistically significant, but it's not near the size of the difference between people identifying as male and people identifying as female. That difference is, it's just harder to be a woman with good well-being than it is to be a man with good well-being. I've had many men ask me, why is that? And I've never had a woman ask me that ever. So regardless of well-being metric you're looking at, whether it's work-life integration or depression, anxiety, or emotional exhaustion, or professional fulfillment, there are those gender differences. There's another question. Or do some interventions work better for some than others? Yes. I mean, the rough answer is no, but if you want a more nuanced answer, people under 30 relative to people over 50 years old have different levels of well-being. People under 30 present with more anxiety and depression. People over 50% with less anxiety and depression on average. For whatever reason, there's a statistically significant, but not, I don't know that it's a clinically meaningful difference in tool use by people under 30 relative to people over 50. And that is, people over 50 tend to have bigger effects than people under 30. So it's not huge, but it's statistically significant. So to answer your question, there is a generational kind of effect. It's not as big as the gender difference, but there's a generational effect. But you can't find a tool that only works for this group. And a big one is we don't find this. Certain things work for physicians, but not nurses, or nurses but not physicians. We don't find that. But there are huge differences in self-selection into particular interventions. So physicians really like the sleep intervention and the all-in-wonder intervention. And nurses really like the gratitude and the three good things conventions. When you're self-selecting, yes.
But did you notice any other attenuated effects in already how it's out there?
Interesting. So in other words, based on your baseline data in a randomized controlled trial, if you're already doing well, what does that look like? What do you look like in your post relative to people who are starting the intervention with kind of higher levels of or problematic well-being? Yes, what's interesting, and we did this analysis kind of on Zoom about a year ago, where we were looking at profiles. We were trying to establish what the profiles would be. And it turns out you can identify everyone from every one of our randomized controlled trials based on the 5 questions that you just answered, right? We asked that in all of our RCTs. Interestingly enough, a profile of 1 or 2 or 3, all 3 profiles improve statistically significantly from pre to post in the intervention. So even if you're starting with a very low level of burnout, you still see improvement for your group. But it's just barely statistically significant. Whereas for the 2s and the 3s, it's wildly statistically significant. It is very much more clinically meaningful. So it's not that people who are doing really well shouldn't try to do anything for their well-being. It's just that they don't have as much, room to improve as their colleagues. There's a restriction of range issue there. It's a great question. Yes.
Thanks for great talk again.
Inspired by you, my friend.
Great. I appreciate that data about workplace violence. Probably the same answer that people asked about the workplace violence definition and self-defined by the respondents. Bullying is that the same kind of thing where you bully yes and no and it wasn't defined. We probably don't the answer to this, like you have a sense for how that's divided from patients to staff versus staff kind of interaction, because obviously in a leadership standpoint, looking at this data, you're going to approach that thinking you're going to have less ability to control patients.
Right.
Workplace violence events are going to maybe having more.
So for those of you listening on the Zoom, the question was do we know that workplace violence versus bullying was coming from patients and family members versus colleagues? Was that fair summary? So what I can tell you is that was my first question too. And when you look at the comments on the surveys, they give you some indication what it feels like. And this is not definitive, but this is just like a hinting at the beginning of an answer to a really good question. Is workplace violence is almost exclusively them talking about patients and family members. And that bullying and emotional abuse and discrimination, well, less so discrimination, but bullying and emotional abuse are largely talking about colleagues, as colleagues. But we didn't measure that explicitly. That's just a sense you get from reading the examples. It's a great question. Yes.
I just want to say we are out of time. We're actually over time.
Oh,
It's been amazing. So feel free to stick around. But also go back and go to your or anything else. Feel free to.
Awesome. Thank you.